be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.
I'll just stay right here. And I'm going to drop down and back, so I'm fine. Good evening, everyone. Thank you for joining us this evening. Everyone in the room, those of you online through the YouTube live stream and Facebook Live, welcome to the Lung Cancer Living Room from Toronto, Canada. We are so excited to be here. It is our very first time not only, it's my very first time in Toronto, but it's our very first time doing a living room outside of the United States. So we are absolutely thrilled to be doing it here tonight with Dr. Francis Shepherd and Dr. Natasha Leighl from Princess Margaret. I am overwhelmed by this country and the welcome that we've had here. So thank you all for joining us. Tonight we're going to be talking, I should introduce myself. I'm Danielle Hicks. I'm from GoTo Foundation, and my role there is to oversee all patient support services and programs. So anything and everything that has to do with patient touch, not just in the United States, but globally, is my area of responsibility. So that's me. That's who I am. We're going to be talking tonight about two different we're going to have two different buckets that we're going to be discussing. One is sort of the landscape of lung cancer. What does lung cancer look like today? And then we're going to be talking about what's happening in lung cancer. What's new and exciting? What are some cool things coming down the pike that are going to be of interest to those living with lung cancer today, and those to be diagnosed, unfortunately, tomorrow. That's the reality of where we are. I would typically do an around the room, but I think what I'm going to do tonight is I'm going to go ahead and ask our speakers to introduce themselves. Historically, so we've been doing the living room. This past August, it's been 10 years that we've been doing the living room. So I used to read people's bios from a piece of paper, and it was extremely impersonal. And so what I've been doing the last year and a half or 2 years is asking our panelists to introduce themselves, tell us not only who they are and about all of the amazing things they're doing, but why lung cancer matters to them. I think it just makes it more personal and makes it for an easy conversation. I want to remind everyone online and people in the room, if you have questions, this is meant to be an interactive meeting. We do this for you. We want you to participate and be part of this. So please, please, please don't hesitate to ask questions. Michelle's monitoring the YouTube live stream, and then we have my colleague Jennifer back in California monitoring the Facebook Live, making sure that we get your questions here so that you can take advantage of these amazing speakers we have here today. So with that, I'm going to turn it over to Drs. Shepherd and Leighl to give us a little introduction of who they are.
I'll start. Thank you very much for coming, and for all of you who are out there on the net, welcome as well. It's too bad you're not here with us in Toronto. Toronto is a hidden gem. So you might even consider coming to visit at some time in the future. I'm a medical oncologist. I treat only lung cancer, so every day of my life I'm treating lung cancer patients, and I've been doing it Princess Margaret Hospital and the University Health Network for over 40 years now. We have an incredible multidisciplinary team at our hospital. As I say, lung cancer is a team sport. It's not golf. You have to do it as a team, and we have a wonderful team. And one of my best collaborators here is Dr. Leighl, and I'll let her introduce herself.
Thank you. My name's Natasha Leighl. I'm currently the lead of our lung group, which really means that everyone else tells me which direction to go in and I follow. I was lucky enough at the start of my cancer career to meet Dr. Shepherd, who was very passionate and is still very passionate about lung cancer, and she inspired me to try and follow in her footsteps. It's really been an amazing ride. Today in clinic, we had a nurse who first worked with me 17 years ago in lung cancer. And she said to me at the end that she was so thrilled to see all of the changes, the targeted therapies, the immune therapy. She said it was so great to see people come in and out with smiles on their faces, to see people working and living longer, better than ever. And I think we need to thank also all of our patients who've really helped us get this far.
Great, thank you. Larry, do you want to do a pickup and introduce yourself and start that off for the room? There's a microphone right here. Sorry. By pickup, that's what I meant. My apologies. So for everybody in the room, just so the folks online can hear you, we can all hear you, but anybody watching needs to hear you through a mic.
Got it. This message is to the panel. Where do you see us going 5 years from now with regards to both immunotherapy and targeted therapy, since those are the forerunners of precision medicine?
Sorry. I love that question, but what I meant was introduce you and who you are, and then we'll get to those questions.
Okay.
Sorry.
Hold that thought.
I'm a patient. I'm a patient at Princess Margaret Hospital, and my oncologist is sitting right up there, Dr. Leighl, wonderful physician and wonderful facility. It has state-of-the-art equipment, and research is just mind-boggling. And I was initially treated in the United States, where I had fantastic treatment as well. And I'm right now almost 3.5 years survivor, and NAD. Love those words. Love those letters.
Love them too.
And I hope that
And
stays
cleared
for
your blood.
Great. Thanks, Larry. If anybody else wants to introduce themselves? No. It's okay. Nobody has to.
So my name is Andrea Redway. I'm a stage 4 lung cancer survivor. Was diagnosed in 2015. Did 2 years of immunotherapy and have now been off treatment for 2 years, and I'm doing great. And I'm from Ottawa, living in Ottawa right now, and so I'm a patient at the Ottawa Hospital.
That's great.
Which has an excellent cancer center too.
That's great. Thanks for sharing, Andrea. We actually had a living room back home in California on Tuesday night, and we have a patient in there who was on IO for about the same amount of time, and he's been off for about a year too. And I'm really interested in what might be going on there. So hopefully we'll get to talk a little bit about that tonight. That's great. You guys want to go ahead? Mm-hmm.
Hi, my name's Marianne Bradley. I'm a lung cancer advocate. I am from St. Catharines, which is a small town just outside of Toronto. And I am a stage 1 lung cancer survivor. I had an adenocarcinoma in 2014, for which I had VATS surgery on my upper right lobe, lobectomy. And I am NED and doing well, living with lung cancer.
That's great. Thanks, Marianne. Michelle, you want to pass the mic over here?
Hi, my name is Malka Green. I actually work at the Princess Margaret Cancer Foundation, where I'm very privileged to be able to work with the lung group and have the really amazing honor to work with Dr. Shepherd and Dr. Leighl in my capacity. For me, lung cancer is also a personal connection. My mother's a 16-year lung cancer survivor now from her first stage 3B lung cancer, and 2-year survivor of a stage 1 cancer with lots of little nodules that are being watched. So anyway, it's very personal, and I really appreciate the people here tonight and the great work of the team at the Princess Margaret Cancer Center.
Thanks, Mocha.
Thank you.
And I'm Lynn Patterson, and I was diagnosed with stage 4 lung cancer about a year and a bit ago. And I was diagnosed at St. Joe's Hospital, and they gave me the choice about where do I want to be treated. Do I want to go to one hospital closer to where I live, or Princess Margaret? And I thought, I don't know. Well, I guess Princess Margaret, since it's a top 5 hospital in the world. And I was lucky enough to draw you as my oncologist. And then all of a sudden it became clear to me what that really meant. So that's a privilege of living in a city like Toronto, that's for sure.
That's awesome. Thank you, thank you, thank you. Michelle, does anybody online want to say hello or speak up? Nope. Okay. With that, we are going to jump into tonight's presentation. So I'm going to ask Dr. Shepard to come up, and we'll get started.
So thank you very much. I thought that I would just start with a little overview about lung cancer, an introduction to lung cancer, and some of the challenges that we face in Canada. So some of this may be very specific for Canadians, for those of you who are online and aren't from Canada, but I thought we had to give it a little bit of a maple leaf twist while we're here in Canada. So I'm extremely competitive, and I love to be number one. And sadly, though, lung cancer is the number one cause of cancer mortality for both men and women. More women get breast cancer, but more women die of lung cancer than breast cancer. Lung cancer is an incredible women's issue, but it has not been taken up by the women as a women's issue. And that's, I think, something that we should be thinking about in the future. More men get prostate cancer, but almost no one dies of prostate cancer. Only 15% of patients die of prostate cancer. And of course, more men, of course, die of lung cancer. So smoking's always the elephant in the room, isn't it? So I always say, smoking's not a sin. We smoke, we drink, we eat too much. There are lots of pleasurable things we do. And for many years, we really didn't know all of the negative effects of smoking. We have learned, but smoking is still with us, and smoking is with us in our youth. And young women smoke as a way to maintain their body image and control their weight. And that's something we really should be addressing. And in case any of you want to ask me about marijuana and lung cancer, I don't know. The answer I usually give is you can smoke 20 or 30 cigarettes a day. I'm not sure you can smoke 20 or 30 joints of marijuana a day and survive. So we just do not have the true data on marijuana. So I will just deflect any potential questions about marijuana right here and now. So what are the types of lung cancer? Non-small cell lung cancer is the big one, and that's broken down into adenocarcinoma, squamous cell carcinoma, and other minor subtypes. They are all associated with smoking. The one that's seen in patients who don't smoke is usually adenocarcinoma. Small cell lung cancer, the most virulent, fast-growing of lung cancers, is only about 50% now. And mesothelioma is the cancer of the lining of the lung that is seen in asbestos workers. And Canada is a big asbestos country. You know, we have a city in Quebec called Asbestos. And we have been castigated for still actually producing asbestos and exporting it to the third world. But that now is coming to an end. So let's get back to the smoking issue. And not all lung cancers are seen in smokers. And in particular, women, 20% of women who have lung cancer have never smoked in their lives, and really don't have a home exposure or another toxin exposure to understand why they get lung cancer. And then in addition to that, we have 50% of people that we see that are former smokers. You know, the message got out, smoking's bad for you, they stopped smoking, but it takes 15 years for your risk of lung cancer to come back to that of a non-smoker after you stop smoking. So although that elephant is there in the room with us, we have a large percentage, a significant percentage, considering the numbers of lung cancer, who are never smokers, and half of them are non-smokers. So, yes.
Yes, it's on. Yeah, there we go. I'm just curious if smoking is as heavily stigmatized in Canada as it is in the U.S. Like, we see it as a huge barrier to a lot of things, and I'm just wondering if it's the same here, if there's a stigma associated with it.
I think there is, and I'll ask Natasha what her thoughts are, but I'll give you my own personal thoughts. These are thoughts, not science. Sure. They're thoughts. Lung cancer is terribly stigmatized because of smoking. Smoking is associated with COPD. It's associated with heart attacks. You never hear the stigma if you have a heart attack of being a smoker. That's the major risk for heart attacks, is smoking. But that stigma doesn't stick to the cardiac patients, to the stroke patients. All vascular things are associated with smoking. But the stigma is really, really focused on lung cancer. So I would say, yes, there is a stigma. And I'll see what Natasha has to say about it.
It's attributing to barriers, or at least historically, I know things are happening now, and we're going to talk about that. But
So I think that stigma of tobacco is, I agree with Francis and you absolutely, I mean, it's tremendous. And it's fairly specific to lung cancer. You know, we were very lucky in one respect. Canada's actually been the world leader in tobacco avoidance, banning tobacco, taxing tobacco, and we've actually taught even our neighbors south of the border a bit about how that can be achieved.
Air Canada was the first airline to go smoke-free.
Really?
But the challenge was, you know, in that marketing and in those campaigns to change public opinion, we told people that the worst thing that could happen to them was they would get lung cancer, therefore it became you smoke, therefore you deserve it. And that stigma has changed minds. It has really decreased the use of tobacco in Canada. It's really changed what we do in this country, but the stigma has remained. And so, yes, it has been a real challenge. You know, we get about 7% of government funding for lung cancer. But we get 1% of public donations, and for every dollar that goes to breast cancer, we get about 7 cents to lung cancer, and that's all because of the tobacco stigma.
Mm-hmm. Yeah, I'm just curious. This has been a big conversation, for a lot of years now within the Go-To Foundation, and it's been coming up a lot lately about, and particularly as even it relates to potentially screening, and I think we're going to talk a little bit about that, so I don't want to derail the conversation, but I know just on a personal story, and some of you may have watched The Living Room on Tuesday, this came up, where I don't technically qualify based on current screening criteria in the U.S., but I made a decision based on 3 generations of family members, including Bonnie, my mom, who were diagnosed and unfortunately, 3 of them passed and my mom did not, to go and self-pay and get a low-dose CT. And I gotta tell you, one of the barriers is 1,000,000% being terrified that the answer is gonna be yes. Because and my sister and I did it together, so we talk about all of these barriers, the 2% of people who qualify in the US, I don't know what it is in Canada that actually do get screened, but that don't go.
I'm going to address this, actually, yes.
It's crazy.
Yes.
So,
Yeah.
anyway, yeah.
So, what can I say about this? No one deserves lung cancer. And we do a lot of things that are not healthy. If you're obese, have you ever heard of any physician or any group that would deny insulin or diabetes treatment to obese patients who have diabetes because they are obese? Of course not. Of course not. It is something that really is focused on lung cancer and shouldn't be. And I just end by saying it again. No one deserves lung cancer, right? So back to lung cancer in general now. We divided a third. Stage 1 and 2, about a third. Stage 3, which has spread to the local glands in the center of the chest. And stage 4, that has spread outside the chest. Stage 1 and 2, we undertake surgery for cure, But look at those survival curves. You will see that we're only curing about a half of stage 2. Stage 3, we treat with chemotherapy and radiation of curative intent. And stage 4, palliative chemotherapy, and now other systemic treatments, and I'll get into the other systemic treatments in a bit. So how can we improve the cure rates for lung cancer? Well, prevention is everything, and we can prevent the majority of lung cancers with smoking cessation, and that's all I'm going to say about that. But I'm just going to focus a little bit, since you brought up the issue about early detection. Mammograms. Is there anyone in this room that doesn't have a mammogram? We've been doing mammograms for years. Well, yes, Larry. Bless your heart, we don't expect you to go for a mammogram. Do you get your PSA checked, Larry? PSA for prostate cancer. Pap smears. With the exception of Larry, everyone in this room has had 1 million pap smears. Screening for cancer works. It finds cancer early, it finds cancer at a curable stage, and it prevents cancer deaths. And that's been shown for cervix cancer, for breast cancer, a little bit less for prostate cancer.
I just want to make a comment, because you are 1,000,000% right in what you're saying. I know this. I preach this to every choir that will listen when it comes to screening. Yet still, I was terrified. And it caused me to kind of look in this different sort of direction about it, right? And I don't know whether that had to do with stigma, whether it had to do with statistics, and how long it's taken for lung cancer to finally be on this upward, sort of climb. I don't know what it was, but I can't drive home enough Dr. Shepard's point and Dr. Leigh's points about screening and how important it is.
Yes. So I'm speaking to the women here, Larry. You can cover your ears. Having mammograms is horrible. You get your breast squished in this horrible machine. Yet to screen for lung cancer, you would think, well, all you need to do is a chest x-ray. It's easy. It takes a second or two. But chest x-ray screening doesn't work. Here is the PLCO, prostate, lung, and colon lung cancer screening, cancer screening study that was done in North America, and we did not reduce the death rates or the incidence of lung cancer with chest x-ray screening. Chest x-ray is too insensitive. By the time you see it on a chest x-ray, it is often spread into the nodes. But all that changed with the introduction of computed tomographic screening. And computed tomographic screening has changed miraculously over the last 20 years. And now you can do a whole scan, a spiral CT scan, with one breath hold in the time it takes to do a chest x-ray. You don't even have to do the PA and the lateral. The radiologists tell me it takes more time to get the patient undressed, and positioned than to do the scan. So where are we with that? The big national lung cancer screening study, we were not allowed to participate. We desperately wanted to participate, but they wouldn't take anyone outside the US. So we set up our own screening program at the Princess Margaret. But look at this. It reduced the number of lung cancer deaths. More lung cancers were found, but the death rate was reduced, and the survival was improved by a whopping 20%. There is no mammography study that has ever shown a result like that. Well, everyone was blown out of the water. We believed in it, but we needed more proof. So last year at the World Lung, held right here in Toronto, down the street from your hotel, was the Nelson trial, and that was the European equivalent. There are little differences, but I'm not going to get into that. But basically, it was CT screening versus a chest x-ray screening. And look at the absolute difference in lung cancer. These are huge. You can drive a truck through these. You don't need to be a statistician to know that this is clinically meaningful and statistically important. But look at the reduction in lung cancer mortality in women. Lung cancer is a woman's issue. We've got to get the women on board. Do you know that the women's magazines won't advertise about lung cancer? It's not our image. We want to be beautiful. They won't take on lung cancer. But it is a major women's issue. And that's why we've got all these women in the room. We've got women up at the podium. And thank you for coming, Larry. You're not just a token. Believe me, you are not just a token. Okay? But look at the reduction at 8 years, a 60% reduction, 50% at 9 years, and 40% at 10 years. That's huge. That's better than mammography, better than PSA screening. And in the Globe and Mail, and I've highlighted, the Globe and Mail is our big national newspaper. Think of it as the New York Times of Canada. 3 years ago, last March 2016, 3.5 years ago, the Canadian Task Force recommends CT screening. Somehow or other, it's gone a bit off kilter there. And where are we 3.5 years later? Where is the US 3.5 years later? Where is the UK 3.5 years later? The uptake of CT screening is extremely low. Extremely low among smokers. Why is that? This saves lives. I don't know the answer to why it is.
Being the only male here.
Yes, it's okay. We're not going to ask you about your prostate.
Okay, no problem. I think the big thing is with smokers or non-smokers or whatever, the average person is like an ostrich with his head in the ground.
Yes.
If he doesn't know it, and the study that you talking about, there was one done at Memorial in Florida, Memorial Hospital in Florida, and their turnout, and they were offering free diagnostic CTs. The turnout was terrible.
Yeah.
So I think that's the problem. They have to get somebody to force them to go.
Yes, and you see, it's not the lung cancer doctors that can do that.
Yeah.
It is the primary care physicians who have to be educated and embrace this. How many primary care physicians would not send a woman for a mammogram or do a pap smear?
So I agree that awareness is the issue for this. So I do organize an awareness table, for lung cancer awareness table at the Ottawa Hospital Cancer Centre every month. Just volunteers. We're all lung cancer patients that man it. And there is a pilot program, as I'm sure you know, in Ottawa on lung cancer screening. I cannot get the people running that program to let us distribute the materials at our lung cancer awareness table because they have a fear that the people who are coming through the cancer center already have cancer and they don't want to, they'll think that this screening might apply to them and it doesn't. Or anyway, I don't really understand why there's that disconnect because lung cancer patients are the ones who are sensitized that know that this is important and will spread the information to their family and friends.
We have the same philosophy, actually, about people not wanting to come to the cancer center. So we've had an Ontario mammography screening program for years. And the mammography is done at the Princess Margaret. And when the Princess Margaret moved from Sherbourne Street over to University Avenue, and they were building all the new buildings, do you know we had to build a separate private elevator for the women to go up for mammography so they did not pass through the waiting room and see the sick cancer patients?
It's crazy.
It's absolutely crazy.
It's crazy.
You know, a cancer hospital maybe should be for screening, it should be for prevention and treatment.
Yeah.
And maybe seeing some of these patients who have cancer might be a good way to spur them on to keep coming for their annual tests. Who
Right.
knows? I don't know the psychology of it. I'm not a psychiatrist.
And I'll just comment on your other issue on women getting more involved, and there are a group of us of women who are getting more involved in advocacy for lung cancer in Canada. But I was disappointed again at the Ottawa Hospital to have this women's health center open up last year. And somebody sent me up and said, go look at this, it's wonderful. And I said, oh, great, I'll go have a look. And I discovered it was a women's breast health center is actually what it's called.
Absolutely. Lung
And it had
cancer's
nothing to
never
do with
included in
any
women's health.
So,
You're right.
you know, another disappointment that something has been huge that's been
Yes.
missed. So.
I think this is where people in the room, people watching, people who will come back and watch this can really help, right? Because you said it, you're going to be talking about it, people will listen to you. And we bring up screening at the living rooms all the time, which seems sort of ridiculous because the people in the room are patients. They've already been diagnosed.
Yes, both
but I always,
barn door after
right.
Yes.
But I always remind them that they are the best people to be out there talking about it, right? To be saying, don't be afraid, right? If you qualify, get screened. Look at the statistics. I mean, you guys can have these slides, right? They'll be on the video afterwards to talk to them about it. In the U.S., to your point, Dr. Shepard, the problem is with the primary care physicians.
Yes.
The AFP is not behind this, and they want to talk about radiation, right? And this came up Tuesday at the last living room. I got the same amount, if not more, radiation flying here and back to San Francisco
Absolutely. Yes,
than my
this
CT scan a
single
month
breath
ago.
hold CT scan has very low level of radiation, yeah.
That's what I was just going to mention, that I happen to have a really good primary physician who just happened to say, we're going to send you for a scan. I don't know why. I wouldn't have asked for it. Like, I don't think the onus should be on a patient. If I had lung cancer, I wouldn't be at this thing. I wouldn't care about it. I wouldn't read a damn thing about lung cancer, and that's the truth. My primary physician sent me, and it was just by her smartness of doing that. So who's in charge of the curriculum? Like, why do I get a mammogram and a pap smear as a matter of a checklist, and I don't get a scan? Because I'm a non-smoker, so why would I get one? So
Yeah,
Where does that- how does that get
never,
triggered?
sadly, you will never fall into a risk group for which lung cancer screening would be justifiable in any healthcare system. So I don't know how we can target the non-smokers. Maybe sometimes a family history. You've got the family history. But do you have any thoughts about how we can target non-smokers?
So I think as technology moves forward, I think there will be more and more things available. In Taiwan, for example, they're almost finished a screening study for never smokers for lung cancer. And so I think, when we look at people that are at the highest risk, people with a family history, we're also learning more about blood markers, and we were talking with Larry about breathomics, or the ability to sort of exhale breath, and maybe you can pick up more than one abnormality. And so I think that today we're not there yet, but could we be there in 10 years? Will there be simple, affordable technologies to sort of stream people into high risk, low risk, no risk? I'm hopeful.
Yeah, and I kind of think that with some of the blood-based stuff, there's a ton of companies in the U.S. working on this, right? And sort of right now, you're kind of like, oh, so we see cancer in the blood. Well, now what? Because we can't see it anywhere else. We don't know where it is. We don't know what do we treat it with, right? So there's that whole thing. But as a companion, or maybe a first step towards, oh, maybe now you should get a CT scan. I think that's probably closer in the future, right? Which is huge. But right now, and this is, I keep putting my foot down about it because it's the low-hanging fruit, right? These people that qualify today, even though you have to be current or former smokers with a fairly heavy, pack year history. It's low-hanging fruit
That is the low-hanging fruit, yes. Yes, as compared to every single woman on the planet who gets mammogram.
Oh, and I also wanted to say, so again, in the U.S., but I think, we're all friends, Canada, U.S.,
Yes.
all of us, and we can work together. We've been working as go-to on a Women in Lung Cancer, the act, this bill, this whole thing went through Congress, so we'll talk about it after.
Dr. Shepard, I would like to ask you a question about how do oncologists in general feel about the low-dose CAT scan screening? Because I'm getting, as an advocate, I'm getting mixed reviews there. Some feel it's extremely necessary. Others are saying no because of the risk factors involved
Oh, no,
in
no,
the
no.
low-dose screening.
I don't know what you mean by the risk factors. I don't know whether you mean the risk factors that we use to identify the proper patient population to screen, and there is fine tuning of that going on. And certainly smoking is the number one, pack years is the number one risk factor that we choose. And we have investigators here in this country, Martin Tamamagi in particular, who is trying to develop algorithms to really refine the risk factors and adding in COPD and other things to identify the highest risk groups. In terms of the risk of the procedure itself, I think the benefits far outweigh the risks. Myself personally, I'm extremely pro. The minute I heard about it from Claudia Henschke and their group in New York, who were just doing these single-arm trials, I wanted to get it established here, and we had incredible donor support with $500,000 a year that came to us from one of my patients to establish our screening study. So we had a very large screening study at Princess Margaret. So.
And I think part of the challenge has also been that when people were initially reporting the results of these studies, if you found any spot and it wasn't cancer, that was considered a bad outcome.
Yes.
But we've actually learned so much more now just by the way that they appear on the CT scans. We've got better technology. Blood tests maybe will help. I mean, we're so much better at knowing when a spot is concerning and when we shouldn't send somebody for a biopsy. And so I think we're really improving that risk-benefit ratio.
Oh, yes. If that's what you're getting, that now I understand. Yes, there was a lot of overdiagnosis of nodules because a very large percentage of smokers have nodules, the vast majority of which are benign. But invasive procedures are required to diagnose lung cancer. And invasive procedures of an organ where there are risks to doing that, particularly when the organ is diseased from heavy smoking. So there's been a big learning curve at understanding the nodules and developing flow steps as to if the nodule has certain characteristics, you repeat at certain time, or immediately go to a biopsy, or repeat 6 months later or a year later, etc. And one of the new things, and I don't know enough about this, will be artificial intelligence. So can we bring in a computer, the computer has to be taught, of course, to be able to read these nodules and say, this has a very high risk of being malignant, this doesn't. This is an area of current and in the immediate future research to see whether artificial intelligence can help us know which are the lung nodules that we should worry about and which can we send the patients off for 6 months to a year. So yes, glad you picked up on that, yes.
So good evening, everyone. I'm Christina. I'm with Lung Cancer Canada. And I think one of the barriers to lung cancer screening in Canada has been that the Canadian Task Force for Preventative Health, their initial recommendation was that it was a weak recommendation. And so I think governments have been able to hide behind that, and provinces have been able to say, let's do pilots, let's do further studies. But with that new data that you've just been showing, I think as an advocacy point, we have to get those recommendations changed
but
to
we
a strong
still are living in the pilot era.
Yes.
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 Yes. Particularly in our province with Cancer Care Ontario.
And even not in the pilot area. I mean, Medicare approved screening in the U.S. a few years ago, and we still have less than than 2% to
Yes.
3% of the
Yes.
qualified people getting screening.
Yes.
Anyway, I love all this conversation around screening because I think it is oh so important for the future. But I want to make sure we get through some of the good stuff, the other good stuff.
I thought I was just going to speak for about 5 minutes, so I've taken up too much time. But I'm getting really near the end because I'm not going to go into any details of what's coming because I'm going to leave that to our open forum. So how can we improve the cure rate? And there are two major things that have come to us in the last decade, and that's molecular profiling and molecular targeting of lung cancer and immunotherapy, harnessing the immune system. So lung cancer is truly the poster child for molecularly targeted therapy. There is no other cancer out there that has as many driver mutation targets for which drugs are being developed. And the changes that are taking place are happening at lightning speed. We have gone from first to third generation EGFR TKIs. EGFR is the biggest one for us. We've gone from first to third generation in about 15 or 20 years maybe now. With ALK, the next biggest one, we've gone from first to third generation, or I sometimes call it fifth generation, between crizotinib and lorlatinib in less than a decade. Less than a decade from the time these mutations were identified. Molecularly targeted therapy is mainly for women's cancers and mainly for non-smoking cancer. We don't exactly understand the why, but 3/4 of the EGFR, more than half of the ALK, half of the BRAF, etc., they are in lifetime non-smokers. And many of them, for EGFR, 3/4 are women. ALK and BRAF, etc., maybe half and half. So what are our challenges here? We have, so what happens? The molecularly targeted agents are being developed at lightning speed by the pharmaceutical industry, and that's fabulous, absolutely fabulous. They are being brought for approval for marketing, and that's happening fairly rapidly too. And we are even getting faster approvals, mainly in the US and to some degree in Europe and to a lesser degree in Canada, approvals based on single-arm phase 2 studies with a commitment to do a randomized trial. So there are many targeted agents that are approved. In Canada, though, the next step for us, and it's the same in Europe, so you go to EMA, and EMA approves the sale, and then every country decides whether they'll pay for it. Canada's like EMA. Health Canada approves for sale, and then each province decides if they will pay for it. And often this comes out of a cancer budget. So what do we have? We have treatment for ALK, and we have treatment for EGFR. But there are lots of other targets out there for which there are drugs available, but not paid for through our healthcare system. So this is a challenge for us. If you happen to work for a company that has very nice drug insurance, then you can get it paid for. If you happen to have an oncologist that will go the extra mile, there may be compassionate programs and you fill out all the forms, etc., etc. But we should have equal access. For drugs that have more than a 50% response rate, we should have access to those. Payment as access.
So of course I have another question. Clearly it's hard for me to keep quiet. But so do you think that I'm really curious about this because I'm curious about how we can help. We as GoTo and we as with the folks out here in Canada, how can we work on this? Do you think that it's sort of this double-edged sword where The exciting thing is that all of these things are happening, and they're happening fast, and they're happening furiously. But it's also the challenge because they're happening fast and they're happening furiously.
Well, to a certain extent, we've got a bit of a yin and a yang, and I don't know what the good part of the yin and the yang is, but the good part is that these drugs are very active, very high response rates, unprecedented response rates, not what we see with chemotherapy, and toxicity profiles that are far better than chemotherapy. So that's wonderful. Some of them are very low frequency, 1% or 2%, and we don't have randomized data. And we are still living in an era for reimbursement, not approval, but reimbursement, of wanting randomized data. So for instance, BRAF was turned down by PCODR. So PCODR is the Pan-Canadian Oncology Drug Review that takes a drug and reviews its kind of cost effectiveness after it's approved by Health Canada. And it makes a recommendation. Yes, this should be approved. And then there will be some wording of contingent on finding a pricing structure that is compatible with the Canadian healthcare system. There'll be words to that effect. And then the next thing is a black box, like this computer, and none of us knows what happens in the black box, and we never know what comes out the other end either. And the drug company goes in to negotiate the price. So it's never the list price, but we don't know what the price is. If you pass PCODR, then eventually the company will come with an acceptable price, for the most part. PCODR turned down BRAF inhibition with MEK inhibition for BRAF mutations, right? We have no...
So with these with these patients with the ROS1 and the BRAF and the NTRK and all these things we know we have targeted agents for, what do they get?
So most of the access in Canada, we either do it through trials, through special programs, or we work with advocacy groups to try and lobby for accelerated funding. You know, it's interesting, the BRAF example, you know, if we'd had no new drugs in lung cancer and it was the first new drug in 10 years, we probably would have gotten through. Yes. But there was a sense, and you know, I can't confirm it 100%, a sense of, didn't we just approve 3 new immunotherapy drugs for you guys and you want this now?
Yes.
You know, so I think there is a little bit of, you know, we are to some extent victims of our success.
We are victims of our success. We've had a lot of expensive approvals. But EML4 ALK. So we have first line crizotinib, we have second line ceritinib. Brigatinib has just been turned down at the PCODR level because the randomized data are not mature yet. So
Super frustrating. I mean,
just within the last few weeks. Yes. Yes. So we do have our issues. You know, it's been amazing. We have no NTRK drug approved. We get compassionate crizotinib for ROS1, I think. I don't think the government pays for it, does it?
I think it's under negotiation.
It's under negotiation.
But
It's
even
in that black box.
ROS1, and I might be remembering this wrong, but Genentech just released a press release, right? That it's tumor agnostic. Like now they've got a drug.
Oh, I think that's for TRK inhibitors.
Is it TRK?
NTRK.
Was it for
NTRK
Genentech?
goes across, yes. Yes.
Yeah.
Maybe.
There's many of the same family of drugs, the NTRK drugs, they target ROS1 as well, so ROS1 may be in on that. Yeah. Anyway, it's been an incredible explosion of knowledge, because really what has changed? What has changed in the last 10 years is technology. It's the technology for us to probe the molecular changes of lung cancer. And it used to be 30 years ago, you had to have a fresh frozen tissue, and we looked at one gene at a time. Now we can examine the whole genome. We can do it from the peripheral blood. What a change, what a change. So personalized or precision medicine requires rapid molecular profiling to identify the cancers, molecularly laboratories are not widely available to do the latest technology. And we do not have a healthcare system that will drop $5,000 US for every patient to send it off to Foundation Medicine. We have to get this integrated into our hospitals. Now, every little regional hospital around the province or country should not be doing molecular profiling. It has to be centralized, but it should be available to everyone in a timely fashion and at the latest level. Yeah.
I saw you present these 2 slides last year in Lung Cancer Awareness Month down at the Globe and Mail building.
Oh, yes.
And I'd
Okay,
been going through a couple of months of despair about poor me. I've got stage 4 lung
Yes,
cancer, don't know where
yes.
it came from, never was a smoker. Those 2 slides made me more optimistic than almost anything other than Dr. Leighl put me on alectinib.
Yes, yes.
Because what it said was, wow, of all the unlucky people, and you said to me, Dr. Leighl, of all the lung cancers to have, this is
you
the
got the
one to
best.
have.
You
And
got
I
the
thought,
best, yeah.
what are you talking about? You're crazy. That slide made it real for me, so thank you for
You
that,
won
and thank
the
you for
lung
that again.
cancer lottery.
Well, it's ridiculous, but yeah, when you put those 2 slides together, that's very meaningful.
Yes, yes. Okay. So the other thing, the immunotherapy tsunami is upon us. Now, this started with melanoma, and it doesn't matter what immune treatment you give melanoma. You can put the bottle beside the bed and you'll have responders. So I must say I was a little bit skeptical. I have spent 30 plus years doing immunotherapy trials and have never had a really positive one in lung cancer until recently. And now we have 4 approved immunotherapy agents. They're being used now first line. We start in advanced disease. They've moved up to first line. They've moved into maintenance therapy to change the cure rate in stage 3. And there are 4 global trials ongoing, almost completed accrual, of adjuvant immunotherapy post-surgery. This will improve the cure rate. But all of this is important and expensive. And we really have to learn, and all of us are part of it. The patients are part of it, the doctors are part of it, the government's part of it, particularly in Canada. We have to learn to spend our dollars, our euros, whether they're US dollars or Canadian dollars, wisely. And that's where I was going to end in the space of a mere 10 minutes originally. Sorry about that.
Larry's fault, Dr. Shepard. He didn't have his mammogram.
Okay. Yes, all right. Yes, and you did interrupt and ask questions, so it's all your fault.
That's perfect.
Would you like to switch to Dr. Leighl first
would
or
love
take some questions?
Does anybody have any questions they want to? I know we've been kind of doing it throughout, which I love. I love the back and forth. Yeah, I think we can go to Dr. Leighl. Yeah.
Great. Thank you. Thank you so much. So I'm going to switch gears a little bit and talk a bit about some of what is coming to prime time, some of what, in my opinion, should be prime time, some things you might want to ask about if your loved one has lung cancer, as well as a bit about the research that we're doing, largely supported through our foundation and our scientists, including a slide of research that Larry's very interested in. So talk a bit about those. So Dr. Shepard's done a really great job explaining about how in lung cancer we've had this real revolution where if you have one of these gene targets in your cancer and you hit it, you do so much better in the blue line than if we don't find it or we don't hit it with the right kind of treatment in the green line. And I think we all agree, even this with people living years isn't good enough. We really want all of our patients with stage 4 disease to be up here, and that's where we need to go in the next 5 years. But even if you do have a smoking history and you don't have one of these gene targets, we've really had an amazing revolution with immune therapy. We do have some markers of sensitivity, and again, just like the targeted therapy, if you've got these different markers, you can do so much better even just with one simple drug than with chemotherapy. And again, we want this line to be up here, and that's where we need to go in the next couple of years. So it's been great. Dr. Shepard's talked about how, there's just been this explosion in drug development. There's been this explosion in investment in lung cancer, which has really been wonderful for all of us.
These are some of the targets. There's a new target every year. These are some of the drugs. There are several new drugs that are here. And we're learning that lung cancer, we've thought of it as sort of the most common, this huge entity, but in fact it is very, very, very many different small pockets of disease, very, very many rare cancers, and that really changes how we need to approach it. So a lot of what we've been trying to do at the Princess Margaret is make sure that we understand targets and that we are able to make sure that our patients access treatments. And so you go from the level of your genes or your DNA, you make protein from that, something called RNA, which helps you transcribe your proteins, and your proteins really perform all of the functions of your daily cellular functions. So whether it's a cancer cell that needs these proteins to grow and spread, or whether it's normal cells or tumor suppressors that really prevent or protect you from cancer. So in Canada, around now across the country, it's taken us about 10 or 15 years to get 2 genes very reliably tested, and more recently the immunotherapy protein. So 3 things, and yet the truth is that there are probably about 9 or 10 things that we need to be testing for in everyone's cancer. And so part of what we've done is we've been trying to bring this new technology to patients thanks to our foundation, and we found that when we use the technology, and we don't just limit ourselves to 3 genes, we can actually find new therapies for up to 70% of people. So that can really make a huge difference. And part of what we're doing is trying to build that business case and convince government that this is something really important, that they need to invest in this for all of our lung cancer patients across Canada.
That's a great slide. I love that slide.
The other thing that's so interesting, in breast cancer and colon cancer, people often have surgery. I don't mean to be gross, but there are sort of large chunks of tumor floating around in pathology departments. In lung cancer, there's a very famous pathologist called two-cell Tau, and he vowed that he could diagnose anything with 2 cells. But the problem is, I can't find all these abnormalities with 2 cells, and it's also really hard to get these big chunks of tumor unless somebody's had surgery. So liquid biopsies or finding some of the broken down material or genetic material in blood has really made a tremendous difference in lung cancer. We know that up to 40% of people don't have enough tissue for all of the extended testing we want to do. And so if you could just do a blood test, that would make a huge difference. And it's really changed. We've initially worked on looking at, if treatments stop working, can we make some diagnoses and change people's treatments? I'll show you some slides on that. More recently, we've been working at the level of diagnosis. So if we don't have enough tissue, do I really need to ask you to do a new biopsy, or can I just do a blood test and we can make all of our decisions from there? I think that those are really prime time, or should be, in Canada. And even in earlier stage disease, if you have a nodule from screening, can we do a blood test to figure out if it's cancer or not? Can we look at someone where we're not sure about the CT scan or not even sure if they need to have one? And can blood help us inform what we do? And so, for example, I'll have a patient where we don't have enough tissue for all of the markers. We do a blood test. It shows me the marker that's relevant, and then the pathologist can go back and say, okay, I can't do all of the markers, but I can do one, and I'm going to do that one that you found in blood, and that suddenly opens up a whole range of possibilities for people. So, I think we've really learned a lot about, blood tests informing tissue tests and vice versa. So this is a study that we participated in that I think really is bringing blood testing into the prime time, where we found that if you looked in a person's tissue biopsy or in their blood test, by and large, there was a lot of overlap. You found most things by either method, most abnormalities by either method. And in fact, we found more in blood. So in fact, you could do blood tests first and save tissue testing for later. And I think that could make a really big difference. My personal bias is I think this is ready for prime time. I'm ready, if I find something in blood, to go ahead and offer somebody treatment based on that. My pathology colleagues are perhaps not as ready as I am, but I think this is where we're going in the next 1 to 2 years.
So is it the same here? Sorry. Is it the same here where in the U.S., tissue still sort of the gold standard,
Yes.
Obviously, right?
Yes.
But in the U.S., if we see it in the blood, then we know it's there. If we don't see it in the blood, we're not sure it's not. That's kind of, so it's the same kind of.
It's the same thinking.
Yeah.
Yeah. And although I think that we have been a little less trusting, particularly being able to get patients access to trials. The tissue still remain the gold standard, and we're hoping that that will shift and blood will become an acceptable alternative. So, it's interesting if you look at the example of one of the things we learned about, first I thought, there's small cell and then there's not small cell lung cancer or non-small cell. Now I'm learning that there are different specific genomic subtypes. And now I'm learning that a person's cancer doesn't even stay the same over their lifetime. So it used to be that if you had one cancer, why on earth would you repeat the biopsy a year or two later? It's going to be the same cancer. But now we've learned that's actually not the case and that things change. And so, if you're on a drug that kills off the green cells, you might have this one red cell that hides, you go into a remission or you're doing very well, and then suddenly over time it slowly grows and you have this resistance, but it's not the same as the resistance from the green cells. And so this idea that you need to keep repeating the sampling or keep continually getting that real-time snapshot of somebody's molecular profile of their cancer is so important. You're not pincushions. You can't keep doing biopsies every 5 minutes or every 6 months. And so I think this is where blood-based testing really will help us make life so much better for people with lung and other cancers. And so we've really put this into practice with EGFR positive cancer. We led a large Canadian wide study where over at 4 different centers, we were able to get patients across the country to send both their blood and their tissue in. And we found that instead of biopsying somebody, just like in the US, like you mentioned, you could do the blood test first. If we found the marker we were looking for, we could change the treatment. And if we didn't find it, then we could ask people to go on to a biopsy. We were able to decrease the number of biopsies by 60%, save money, save time, save needles. And so it's really made a huge difference. And currently the government is considering this work for funding. Go ahead.
Can I go back a slide, Dr. Leighl?
Sure.
Did I hear you say that I might be ALK positive and ALK positive now, but there could be something hiding somewhere else that we could discover? The slide before this one? Back?
Yes.
Is that what you
Yes.
just said?
It is, and I'll show you an ALK specific slide as well,
Okay.
just so you can get a sense.
And how often would we be tested for that?
So, and I think that this is emerging. So,
Right.
for example, people with EGFR positive disease or ALK positive disease, this blood-based testing is really becoming an accepted standard. And maybe what I'll do is I'll move off for this. One of the questions always is, can you follow levels in blood and change treatment based on that? This is an example of a patient we've been following. Dr. Liu at our program has been collecting blood on patients on different treatments. And in the orange box, you can see a growing number of lines there. That means there's sort of an emerging number of mutations. And a few months later, that patient actually developed growth on their scans, and we needed to change therapy. And what we found in blood actually predicted what we found on the biopsy. And so sometimes blood can be used as an alternative to direct therapy. This is someone who had a different drug than you did. They had crizotinib. And in the blood, you can see that their original abnormality is still there, that EML4 ALK fusion, but now they had new abnormalities and new resistance mutations. And so based on that, you can say, okay, what drug would I have that could target all 3 of these? Just a note of caution. It's really nice that all of these companies tell you what drugs to be on or tell you what trials to be on. The truth is that's not always true. And you really do need to talk to your doctor to understand, okay, what makes sense, what doesn't make sense. What do they say is approved, but it actually doesn't work in my cancer? You do need to have that conversation. These aren't, they're not yet ready for direct to consumer marketing.
Thank you. It's just funny that sometimes I absorb things when I need them, and I didn't know about this until just now, so thank you.
And I promise you, I hope you and I don't need to talk about blood-based testing for years and years, but when we do, we will. And so, with those different abnormalities that we find, whether it's in blood or in tissue, can we then go to like a map like this and say, okay, we've got 1, we've got 2, we've got 3, what's all green here? And can we use that to help really personalize therapy even better? And so with this explosion of new drugs that are all slightly different, we're hoping that that's the way we're going in even less than 5 years. So part of what we're doing, again, similar to the tissue testing, we're trying to really prove that this is value added. So we've got a study that we started at the Princess Margaret and we've expanded across Canada. It's called the Value Study, where people get their blood-based testing, whether it's before they start therapy or if treatment's not working anymore. We get a result in about 6 or 7 days based on the blood, and then we're trying to show how much that really adds. And so again, this idea that, it's not just for those who can pay or who have the coverage, but for all Canadians. So what are some of our challenges? And so, when we struggle in clinic, the things are, okay, so we know the target, we know the treatment, but there's a small number of people where it still doesn't work. So why is that? And so how do we discover how to overcome that? We know the target, we know the treatments, it's working brilliantly for years, but then it stops. So what is it? Is it the red cell? What is that emerging element of resistance? We know the target, we know it's important. We don't yet have a therapy, so how do we find one? And that's some of the research that we also do. And then we have no idea. We can't find any of our known targets. We don't know why this person has lung cancer. We don't know what it would be most sensitive to. And these, areas where we need more discovery, we're really kind of stuck with things like chemotherapy. So a lot of what we've done, and Dr. Shepard's pioneered this program with Dr. Ming Chow, it's been going for over 20 years, I think, is this idea that you could take cancer samples from people and you could grow them elsewhere and make it much easier to test, much harder to put you on trials and make you go through all the treatments. Could we do this elsewhere? And so xenografts would, for example, be other living models or animal models. I apologize to all the PETA followers, please forgive me. But the Princess Margaret has one of the largest collections in the world of different types of lung cancer, and Dr. Shepard and Dr. Chow and the whole team, we look at how we've been able to recreate a person's tumor in that model, and then you can actually do testing. And you can figure out what treatments would work, what wouldn't, and if it doesn't, why not? And so you're able to get a lot of the tumor tissue without going back to the patient and poking them for different samples. Dr. Liu, for example, has a large grant from the Canadian Cancer Society Research Institute where we look at people with EGFR and ALK-positive lung cancer. We're able to grow out these tumors and test them to try and get ahead of the tumor, so to speak, so that we can predict what's going to happen next and help pick out therapy. And this has actually been great. We've got an interesting publication coming out looking at some of the novel mechanisms of why things stop working. And so, we're really excited about these and other studies.
I just want to compliment and congratulate Dr. Shepard on that work, because I think it is fantastic. It is so incredibly important, and I agree with the PETA thing.
Complimenting me. This is our translational research.
Everybody involved. I'm
Ming
complimenting
Chow.
everyone
But
involved.
It's the team sport,
Yeah.
right? It's the team sport. We're the people that have to remember to approach the patients to request the biopsies. If it's not for Dr. Leighl, myself, Dr. Liu, the whole clinical team, Dr. Chow would never get it. But he really is the one that has led this and developed our mouse program. And I have a patient who is really very excited about her mouse and keeps asking about her mouse and has a charm bracelet and bought a mouse charm to put on her charm bracelet.
But I mean, if you think about this, and just to make sure that everybody really understands what that means, it's literally taking your tumor, your cancer, not a cancer, your cancer, and treating your cancer in several different mice, again, sorry, PETA, to determine what will work, what will not work, and more importantly, the why is huge. I mean, anyway, I think it's great.
And so, to carry that work one step further, with Dr. Chow and the team, we've been looking at how do we make this faster, better, cheaper. It's very Canadian. But again, how do we really accelerate things if with the mouse work it's 6 to 12 months, how do we make it 1 to 3? And so now we're starting to grow tumors in basically pots of jelly where we can do the same thing. We can do the drug testing, we can look at sensitivities. And so this is some work that we're working on with Dr. Chow. Again, this idea that maybe we can make things even faster and speed it up even more to help all of us understand more about an individual person's tumor.
Yeah, and have a higher take rate. When we put these tumors in mice, actually the majority of them do not grow in the mice. So we're hoping that with these organoids, as we call them, that we'll have a higher take rate. This is the royal we. This is being done by our scientists.
Yeah, it's very cool, and it's one of those Star Trek-y things. I need to understand it more because it's so mind-blowing. But amazing to see that this is where technology is going, right? It's huge.
And then some of the other ways that we're trying to think about these challenges, sometimes we know the targets, we know the genes that are out there, we've read the scientific journals, we've found it in our own patients, but we don't have good drugs, despite that very, very long list that I showed earlier. So we're starting to work with scientists now to ask, well, how do we figure out, these proteins are important to person X's cancer, can we do drug screens to look at any other potential drugs? Maybe there are drugs out there that are not developed by pharmaceutical companies, maybe there are vitamins or nutraceuticals, different things. And so we're currently embarking in a series of drug screening technology tests to try and see if we can really start matching up drugs where a person has a target, but we don't have a known therapy for it yet. So that's work that we're currently developing and we're doing some fundraising for.
Does that include some drugs sitting on shelves never been used?
Yes. Yes, so some
Or
of these
some
libraries
old
are
drugs
huge.
being repurposed. Repurposed, yes.
So this slide is for Larry. So one of the other things, I talked about sort of going from the gene to the protein, and there's that sort of messaging system. You get some copies, and then you build protein out of that. And we know that not all of your genes work all of the time. We know that your body can turn genes on and off because you need different functions at different times. And some of the ways it does that is something called methylation. You'll probably have heard a bit about that, where basically, if your gene is working, you can see here, there are very few of these, we call them CPG islands, or sort of methylation spots. Most of these spots here are white. But if there is a lot of methylation, you can actually turn off or silence the gene. And you can see that here. And so, we've learned that some cancers are undermethylated, so things are turned on, and some cancers are hyper or overmethylated, so a lot of things are turned off, in particular, the genes that protect you from cancer. And what's interesting in some of the work that we've done, we just published this earlier this year, you can see those little gray dots. So that's actually from blood tests. So we actually didn't have to use tumor samples. This is from blood tests that we were able to collect from patients with lung cancer. And you can see how the gray dots don't really overlap with any of the other colors, which is all other different types of cancer. So pancreas cancer, esophagus, head and neck, gynecologic cancers. And so clearly there's this signature or this specific set of genes that are turned off or on in lung cancer. Building on that, Dr. Shepard's doing some exciting work trying to figure out, well, if we know there's a specific signature, can we say, you've got signature X or you've got signature Y, therefore you're at higher risk, for example, of spread to brain? My team's also doing some research looking at whether, based on these signatures and how they look and change over time, can I predict what mutations you'll have, and can I predict what treatments will work for you? And so, there's a lot of interest in this as an alternate way of figuring out drug sensitivity and treatments. Immunotherapy is very exciting. We can vaccinate people. We can enhance your immune system's response, so your T and B cells, or those cells in the immune system that would go out and kill a cancer. How do we make sure that the cancer can't turn those off? And drugs are one way. So there are these immune therapy or checkpoint inhibitors that a lot of people have been on. They've been very exciting, either by themselves or adding chemotherapy to them. But some of the other things that we're doing at the Princess Margaret is we can actually take a person's tumor, take those T cells or those immune cells that would attack a cancer out, grow them up in a laboratory, and then actually give them back to a patient as part of it's like having a stem cell transplant. And so we've actually got some trials at the Princess Margaret in several cancers, including lung cancer, but also mesothelioma. We're doing some very exciting work where we're actually doing this. So whether it's engineered T cells or whether we take the person's own T cells and grow them out and give them back to try and improve cancer sensitivity. So these are some of the things that we're doing at the Princess Margaret. And of course, the goal is, this is where we were. Dr. Shepard in her early years got us from the black line to the blue line. More recently, we've moved up to, immune therapy with things getting even higher. And of course, we want that straight line with people being cured. And so I think we're slowly making progress towards that. And of course, we need that to be faster. So part of how we do that, of course, are through trials. Both our profiling and some of our other testing programs are through trials. We're very lucky to partner with Lung Cancer Canada, so we send out a blast every month about the different trials that we have. Also, a lot of the work that we do is through the foundation. As you know, research money, especially for lung cancer, is very hard to come by. And so we've been very grateful to have a number of donors, often our patients. Friends of Dr. Shepard's actually raised over $10 million, I think, for lung cancer research with the foundation. And so, if you want to learn the endowed money. So if you want to learn more about that, we'd certainly encourage you to contact Malka here from our foundation. And so with that, I hope Dr. Shepard and I have convinced you that we've made a lot of progress. Obviously, we still need to make more to overcome resistance, to prevent acquired resistance. But I think we're really coming a long way to figuring out what the right treatment is for the right person at the right time. And of course, that Canadian twist to get it for the right price. And that's me. And I hope I haven't killed off all the appetite for questions.
No, so I'm gonna ask a couple of questions just based on some things I heard in the room and some things I just hear in talking with patients, and obviously all these questions are geared towards both of you. We talked about resistance and progression of disease, what is sort of the standard about when do you rebiopsy? Is it at progression? Is it at every progression? And hopefully, again, it's not something we have to talk about for a long, long time. And what is it you're looking for specifically?
So I think where we are currently, what's truly helpful in clinic is if somebody has one of these gene targetable cancers or driver mutations, and the targeted therapy stops working, we've been able to use a blood test when something has been growing on a scan to try and help identify the next step or how the cancer has changed. If there's something that's emerged that's different, to try and help us inform how to change the treatment. So at progression, I think is the most sort of ready to use practical example today in lung cancer. Sometimes you can follow people at every step of the way. I find that the timeline between when something comes up in blood and something comes up on the X-ray, in our studies, they've been very close together. Usually it's within about 3 months. So it doesn't provide you a lot of lead time, but sometimes it helps you start planning the next step. And so in some places where they do blood-based testing fairly routinely, it really sort of helps them plan the next step. For us also, at diagnosis, it's very helpful, for example, if you don't have enough tissue. For immune therapy, I think we're still learning. I think it's clear that genomics or sort of gene abnormalities are important, but I think we're still trying to work out how to capitalize on that. So for someone on immune therapy, for example, it might be less relevant. The other sort of area is to move it up into early stage disease. So I think over the next year, we'll see some really exciting data looking at, after surgery or after somebody has chemotherapy and radiation for stage 3 disease. If you have some of this left in your bloodstream, maybe you need additional therapy. And if you've cleared it, maybe you don't. And so in the future, could we see a world where if you've cleared your blood, you can stop your therapy and take a holiday, and if something comes back, you can restart? Or if you've had surgery and you've cleared your blood, you don't need any more chemotherapy or preventive treatment. If you haven't, then you do, and once you've cleared it, you're good. Is this finally a blood test for cancer? I'm very hopeful. Frances, what do you think?
Well, following the blood is new to lung cancer. It's not new to other cancers. Colorectal cancer has been following CEA. Gynecologic cancers have their markers, and prostate cancer, of course, has the PSA. So those have been markers of response, or after surgery, markers of early relapse. After surgery, you have to decide, do you have a good treatment to offer, and when do you want to offer that treatment? You seldom want to leap in with a treatment based only on a blood test if you can't find any evidence of tumor. And the lead time of the blood test can be quite variable. It can be weeks, it can be months, it can be more than a year. For lung cancer, I think things are a little bit different, particularly for our driver mutation cancers, because what we're learning, and this is all in the last decade or less, is that these cancers that start with driver mutations are very clever, and they develop resistance mutations. So in the very beginning, we only had 1 or 2 drugs, and we talked a lot about treatment beyond progression. And why did we treat beyond progression? Because it was probably slowing the growth, and the option was chemotherapy. And the longer you could keep the chemotherapy wolf away from the door, the better it was. But now, if we can follow and we can find a new mutation that the clever cancer has developed, and if, and this is the big if, we have a targeted therapy for that mutation, then it is worth finding it earlier. I'm much more likely to switch treatment if I find T790M in the blood, because I've got a great oral pill to give. If I don't find a nice mutation that I have a targeted therapy for, then it's chemotherapy. So do I really want to know 6 months earlier or not? So it's basically putting together understanding the molecular evolution and possibly partnering with a new and better treatment.
So, I know what I'm thinking in my head. I hope it comes out as a legible question. Is blood or any liquid currently being used in a way to predict whether there is true progression or if it's, you know, like an oligo sort of thing happening?
So,
And
yes,
if it's not being used, could it?
so no, so yes and no. Yes and no. I mean, we are using T790M in the blood for EGFR mutated lung cancer regularly over and over and over again because we have a great treatment to give. So at the earliest sign of progression on an X-ray, then we'll start doing the T790M testing. If you don't want to change your treatment, you don't need to look for it particularly. In terms of, so we have a specific study, and Dr. Leighl alluded to it. Dr. Satcher is leading a trial in stage 3, looking at the whole tumor mutation burden in the blood, all of the circulating DNA. Before treatment, you get your chemoradiation, it's potentially curative. And then we're doing the molecular profiling in the middle of the treatment, at the end of the treatment, before they start immunotherapy, and then during the immunotherapy. What we don't know yet, we do not have enough data. We know that clearing your DNA from the blood is good. We know that people who clear their DNA live longer than those who don't clear their DNA. And we probably have some hints that the DNA may come back before we see it clinically. If the DNA comes back, should we be initiating treatment sooner? And that really centers around what kind of treatment do you have to offer, and can you treat for cure? If you can't treat for cure, you may want to wait until you have more clinical justification to introduce your treatment.
What about treating for something like a chronic management? Like we're chronically managing for as long as you can, whether you're
Yes.
introducing radiation therapy or something like that. Is that?
Well, we are turning lung cancer into a chronic disease. It used to be something that on average it was months. Now it's years and years. So it has become a chronic disease. So it's becoming the art of medicine as well as the science of medicine to know how to monitor and when to change treatment. And it depends really how effective that treatment is versus how toxic that treatment is. And seldom when a cancer comes back are you treating for cure. So you want to balance the negative effects of the cancer against the negative effects of any other treatment that you have. So it's not a simple thing. It's a bit of magic that all has to come together.
So I agree. I think the technology will decrease the uncertainty for sure. So for example, in the setting of pseudoprogression, would I put money on the fact that you'll probably have elevated ctDNA levels if it's real progression and not if it's pseudoprogression? Sure. You know, it doesn't though take away from that art and the importance of that, you know, the person, what they want, what's important, how affected they are. I think it will be a little bit more sensitive than scans. But again, I think we'll have to put it into context of that art of living well with lung cancer for as long as possible, and this issue of, do you have a good treatment? Is it the right time? You know, what do people want? What's the best for them and for the outcomes that are important?
So the question is, if you clear your DNA, if you clear all of that tumor DNA from the blood, take stage 3. Let's take stage 3 lung cancer, where, you know, if you're pretty optimistic, the cure rate's a third, maybe not that high if you take all comers. And now we're offering immunotherapy. Do you really need immunotherapy if you have cleared your DNA? We do not know that. There are trials ongoing of immunotherapy. We have our single-arm trial ongoing. to try and understand what clearing the DNA means. But if you have a therapy to give that changes the cure rate, if you're going to take a test and say this therapy means we don't need to give, this test means we don't need to give any more therapy, you have to be held to a very high level of evidence. It's a much lower level of evidence to say, well, I might as well add it, it may help. But to take what has been proven in 1,000 patients to change the cure rate and take out this 300 group and say you don't need it, you really have to prove that at a high comfort level, a high statistical level, and that's much harder to do. It's much harder to do to show that someone doesn't need a treatment than it is to show that someone does need it.
And I think the next 5 years will be about
Yes.
building that evidence with these newer technologies to answer these important questions.
Yes.
Who needs it? And we didn't think they did. So people with stage 1 lung cancer that run into trouble, it's not 100%, it needs to be. How do we tell who from whom? And similarly, are we over-treating people? It's certainly become a thing in breast cancer. It would be wonderful over the next 5 to 10 years to make it a big thing in lung cancer, that people don't need the treatment, that they're going to do so well without it. But Dr. Shepard's right. The technology will help us build the evidence, so we have to do that next.
With all the cutting edge technology and research that has been going into lung cancer, clearly all this is happening right now at Princess Margaret, which is like the elite, one of the elite centers of research and location in the whole world. What about the people that live in rural areas like Northwest Territories or Iowa, somewhere in Iowa, where they're hundreds of miles away from a cancer research center, and they don't have, if they have an oncologist, it's a general practitioner that, is not the same. You need, if you have lung cancer or suspect of having lung cancer, you want the top of the line, the rock stars.
You may not always need a rock star. For a lot of cancers, there are guidelines for therapy. And Cancer Care Ontario really has taken a leadership role in developing some of the most exquisite and complete guidelines for the treatment of cancer. And the American Society of Clinical Oncology also has guideline panels, and basically they partnered with Cancer Care Ontario because there was no point in repeating. They couldn't improve on the CCO guidelines, so they've often partnered with CCO. And then there are other organizations, there's the NCCN, and there are all kinds of guidelines. And many, if not most oncologists, I would think, no matter where you are, will be practicing according to guidelines. What do you get at a big cancer center like Princess Margaret or MD Anderson or Sloan Kettering? You may get more access to research. You may get more access to new drugs. And we have a very large phase 1 drug program. But you have to remember, you don't want to go to phase 1 until you have exhausted the tried and true that has been proven to have a response rate, proven to prolong the survival. Because phase 1, which will only be at the more cutting edge centers, are drugs that have no track record, and the vast majority of them seldom result in miraculous responses.
I guess the other nice thing about Canada is that we're a network that tends to know each other. So when I worked with Lung Cancer Canada, and with Dr. Shepard and others, we've really tried to build this network across Canada. And so we get emails every day from colleagues who are asking, they have a patient, they want to know if it's worth the patient coming to the Princess Margaret. Is there anything we could offer that they can't? And part of our mission is to really help support our colleagues and people outside of the GTA as well. We make sure that they know about our trials. If we can help facilitate testing or help facilitate access at that center,
will do it. And so there is a lot of contact, and we're really building a great, huge national network. And what's nice is, I'm thrilled to work at the Princess Margaret. I'm so proud, and I think we have resources others don't. But we've also been able to help build it at other centers. So some of these studies that we've presented, that we've started, are at multiple institutions, so patients across the country can access it. So that's been a really positive.
So I just have a comment. I think that's great that the network is that tightly knit here. You mentioned the U.S., Larry, so I just want to point out that this is a problem. It's a challenge, in spite of all the guidelines that are out there. And I think, particularly in the more rural areas, right, where we've got these private practice oncologists who are treating everything that walks through the door, right? Mm-hmm. The expectation that they would know everything there is to know about every cancer that walks through the door is completely unfair and unrealistic, in my opinion. Not to mention, maybe they did check the guidelines 6 months ago, and they think the guidelines have maintained the same standards. When you look at these pie charts and how fast things are happening, just in lung, let alone all the other, solid tumor and blood cancers, because they're treating all of it, I just think it's super unrealistic. And so when we talk to patients all the time, I know personally, if, God forbid, I'm diagnosed, any cancer, you name it, I want to be with a specialist in that cancer, regardless of where I live, or at least a consultation with one, right? And so we constantly tell people all the time, it never, ever, ever hurts to get the opinion of someone who has the benefit of their life's work being in this one space, especially when things are happening so quickly.
Yeah, I think that's true. We are super specialized now. Natasha and I really do nothing but lung cancer. In our early days, we did a lot. Well, I did everything in the very, very beginning, and then had to focus. And part of the thing in being at the Princess Margaret is we really are there. Our prime mission, of course, is to treat our patients. But one of our other major goals is research. And to do research, you really have to focus. One of my old mentors, Dr. Baker, said that years and years and years ago. If you want to succeed in research, you have to focus. And that's a truism for life, I think. You can't be too scattered. And that's how I ended up jettisoning everything else and keeping lung cancer. But
Yeah.
Speaking of research, and there's a lot of great stuff in treatment, happy to hear it. I think I got lung cancer at the right time. Who's working on why women and lung cancer? Is there something specific about women and non-smokers? Like, what are women doing? What is the story? Do we know? Or who's thinking about it?
So it's a great question. I'm going to take a very superficial pass. Everybody is. But the challenge is, how can we make concrete progress? So there are groups and collaboratives where they're looking at women and men. They're looking at the role of estrogen, also looking at the role of atmosphere and geography and genomics. So Dr. Shepard and Dr. Liu and the team, we've collected blood and tissue on people that are never smokers. We've done analyses. We've collaborated with other groups. It's been a very elusive nut to crack. So you can never say never. It's interesting when you look at some of these sort of never smoking cancers, often they tend to be from emerging parts of the world, not only, but often. And so is it other things? We've heard the theory that maybe it's in countries that use more diesel. Could it be radon exposure? Are there genomics or genetic predispositions? And so I think the answer is we don't know. There is a lot of interest. There is work. Frances,
Yes. In terms of lung cancer in women, more women get adenocarcinoma. They're in the early days, at a very simplistic level, it was thought, well, they're using more filtered cigarettes, more refined cigarettes, and the toxins and the hydrocarbons, et cetera, are getting further out into the distal parts of the lung where you get adenocarcinoma. So in the smokers, there's kind of some explanation for it. Is there a genetic explanation? I think in women we tend to see more familial trends, and we see more family history of lung cancer in the non-smokers who get lung cancer, which are largely women, 2/3 of them are women. We also see a history of other cancers. So in the non-smokers with lung cancer, not infrequently they've had a thyroid cancer. Some of the men have had previous testicular cancer as young men. So there's a genetic predisposition, and we don't know what it is. There's no gene for lung cancer. So there's some predisposition that we do not entirely understand. I don't think it's related to hormones. There's been a lot about obesity and breast cancer. That doesn't seem to be the issue in lung cancer, and we've looked at it with Dr. Goodwin, one of our researchers in obesity and the pathways of insulin resistance and things that go along with obesity. And it doesn't really seem to be an answer in women. So that's a long, windy answer to say we don't know.
So I
should be more precise.
Yeah, I have a question because I agree with you, and I've heard sitting in sessions, and this question comes up a lot. Not always just in women too, but just in general. But with women, it's usually like, oh, in the 50s and 60s was the hairspray and the cleaning products, and that was what they did, and they were at home, and that attributed to it, or the human papillomavirus, and that whole thing attributed. So there's all these things. But how helpful would epidemiology studies be in finding sort of these
let me take you back 100 years. When lung cancer was a rare cancer, and before smoking really became prevalent, lung cancer was not a common cancer, but it was a women's cancer. It wasn't seen very often in men. Yes. So that was before smoking. Then along came smoking, and more men smoked than women. And then the women caught up. And so the lung cancer rates skyrocketed in both men and women. But still to this day, in non-smokers, it's 2/3 women to 1/3 men. And it's not... So Kathy Albane and a group in the U.S. in Chicago, they have a great interest in this, and they've been looking at hormonal aspects, and it just doesn't seem to be those estrogens and progesterones, et cetera. It just hasn't really panned out, even though lung cancer can have estrogen receptors on it, but that's not the answer. We thought it might be, but it wasn't.
Does anybody else have any questions before I go up for closing remarks? And anybody online? I know there were some earlier, but 9 times out of 10, online questions get answered just naturally throughout the
keep going.
So someone was asking, why are the major cancer centers not fully sharing info with each other regarding clinical trials? They were talking about the Octane study. And I guess they're going to 2.
So I think one of the challenges is that if you look, all the information is there. So there are actually several groups where, for example, in Ontario or in Canada, you can access all of the clinical trials. It's just a bit of a challenge to get it into a comprehensible format, and then you need to do the homework to sort of contact the investigator at the other site. What we've tried to do is sort of export our trial information as widely as possible. So somebody just clicks the link, they can find out more about it, or just contact us, and then we can interact. So I think there's a lot of work going on to share that information. And there's also a lot of work at trying to match the patient to the trial. So I think we're getting much better at that. Historically, we weren't. Octane is a study that is actually conducted at several centers across the country where they look at molecular profiling. In lung cancer, we've had challenges because people just don't have enough tissue. So one of the slides that I showed is from something where we're using less tissue from lung cancer patients. But we've actually been able to use Octane, a study at McGill, a study at BC, and a number of others, plus our lung cancer study, to put people on the Canadian Cancer Trials Group personalized medicine trial. So there is a lot more sharing. So I hope we're moving forward, but I think it's a good reminder to us that, we can never do enough.
And I think one thing that the major cancer centers are all doing, and maybe not required, but encouraged, is that when you have been doing molecular profiling studies, those are entered in a big open access database. So if we do a little study here and we find that the gene for rhubarb is overexpressed in a certain type of lung cancer and associated with a bad outcome, then you can go and interrogate the databases of other centers and look at their molecular profiling. And there's a COSMIC database that has all of this. Now, it doesn't have all the information. You can't always put together all the outcomes that you would want, but there is a great deal in the last decade of molecular data sharing. So if you find something interesting, you can go and look for it on websites.
And Octane is actually a really nice example of exactly that.
Yes.
Across a number of centers. Yeah.
Anybody else before I stand up? Closing remarks? No? I want to say a huge thank you to Doctors Shepherd and Leighl. I was absolutely fascinated by this conversation. I know we got a little kind of off track, but that's kind of how the living room works. It's meant to be organic and kind of flow based on the questions asked, and in spite of the fact that I hijacked a lot of the questions. I know, right? I think it was spectacular. So huge thank you to both of you for coming out and talking with us tonight in our inaugural lung cancer living room in Toronto. I certainly hope it won't be our last one here. This has been a fabulous time. I'm going to do a little bit of housekeeping for those that are watching. Up next, we have Dr. David Gandera. For those of you who watch the living room, he is not a newbie to the meetings. He's been coming around and speaking at them for the last 10 years since they've been around. So he's coming out to talk about personalized care circa 2019. So what does personalized medicine in lung cancer look like today? That's October 15th. If you can't join us in person, please join us live via YouTube or Facebook. We always welcome you there. October 17th, we will be out in Mexico City at the Latin America Lung Cancer Conference. We're with Dr. Reyes, Dr. Matthias, and Dr. Arrieta. So it's our second international meeting, so we'll be down there. The whole thing will be in Spanish. Michelle and I are a little anxious about that because neither of us speak Spanish, but we're hoping that the translation headset thingies work. So as far as events go, again, for those of you that are watching, or maybe anybody here who wants to head down to Philly on October 6th. So October 6th was our Philadelphia 5K. November 2nd is our Hollywood, Florida, where we met Larry couple of years back, right? And Houston, Texas 5K. So anybody watching from those who want to come out for those community events and spend some time together, please do. Again, I want to give a huge thank you to the patients, caregivers, advocates in the room, online, those of you watching live, those of you who will come back later. You are why we do this. So thank you for participating. To the film crew who did an excellent job tonight, ensuring that we were able to stream to all of you who were hopefully watching from your living rooms at home. To the event space, Vantage Venues, thank you for the setup, the food, everything's been fantastic. Go-to staff in the room, those at home, online, helping to moderate this, a huge thank you to them. And then, of course, I have to give a thank you to our supporters. Without support, we would absolutely not be able to bring this to you. So Amgen, AstraZeneca, Bayer, Boehringer Ingelheim, Bristol Myers Squibb, Celgene, Dignity Health, Foundation Medicine, Genentech, Lilly, Merck, Novartis, Takeda, and Tesaro. Huge thank you for making it possible for us to bring this to our lung cancer community. I want to close by saying Dr. Shepard and Dr. Leighl both said something tonight about the art of medicine, and that there's an art in being able to treat patients. And I believe with everything inside of me that that's their approach to treating their patients, and that it should be the approach of everyone treating patients. So that's something I'm absolutely going to take home with me. So thank you so much for that. And a second takeaway for me, as always, is clinical trial participation. We would not be where we are today without patients like you participating in these studies. Whether it's a study out of necessity, a study because it's the best option for you at that time, or a study that just kind of works in tandem with whatever treatment you're on. They don't always have to be treatment trials and treatment studies. We mentioned an epidemiology study where there's patient-reported outcome studies. There's all kinds of things you can do to help move the needle forward. So I strongly recommend you talk with your physicians about doing that as well. So again, thank you all from Toronto. We want to say good night, and we hope to see you guys soon. Thanks.